Welcome, everyone. Thank you very much for joining us. This is our spring general meeting for healthcare as a human right. Want to thank everyone for helping put this together. It takes a lot of work to put this sort of thing together, and all the work lead up to it. It's quite the undertaking, but I've always looked at the meeting as my favorite part because we've got all our stuff ready to go, and we've got some really great speakers. So without saying much more, I just want to hand it off to Cheryl and Gina, our MC.
Thank you, Nathan. Thank you. So welcome, everyone, and let's get started. My name is Cheryl Wapes'a-Mayes, and I'm an enrolled member of the Assiniboine Sioux Tribe at Fort Peck Reservation in northeastern Montana. I serve on the organizing and steering committees of Healthcare is a Human Right. I also serve on the national board of the National Organization for Women, and I am the president, the current president of Washington State now, and the president of Tacoma now. And Tacoma now is a contributing sponsor of Healthcare is a Human Right. And I want to welcome everyone to this important event. Healthcare is a Human Right. Washington is a coalition of 90 organizations working for healthcare access for all residents of Washington State. And we have some exciting speakers this evening who are sharing their expertise, and I hope you're as excited as I am for this opportunity. But now I am pleased to introduce Gina Owens, who will be emceeing with me tonight. For years, Gina has been a tireless housing and healthcare advocate. Gina serves on the Healthcare as a Human Rights Steering Committee and Washington Community Action Network Board, and is currently co-chair of the Seattle Renters Commission. Take it, Gina.
Good to be here with you, Cheryl, and everybody on the call. So what you're looking at on the screen right now is a display of the traditional lands in Washington State of all the tribes. Let's acknowledge that we work and live on the unceded lands of 29 federal recognized tribes currently without federal recognition, and tribes with ceded land in Washington State, which are Duwamish, Wanapum, which is not pictured on the slide, Chinook, Coeur d'Alene, Nez Perce, Umatilla Confederated, and Warm Springs Confederated, shown on the slide. They've been here since time immemorial and are still here. We must learn from and lift up the many tribes and perspectives as we together create a universal healthcare system in Washington State. There are links on the slide where you can learn more and get more engaged by paying rent to the Duwamish and supporting Native-owned businesses. Now, let's get to a quick overview of HCHR, which is Healthcare is a Human Right. Healthcare is a Human Right Washington is a growing grassroots community labor coalition of 60 plus member organizations formed in 2014 to secure the fundamental right to healthcare for all individuals in Washington State and our nation. We're part of a growing national movement for health justice. We have won some important victories along the way and are in a stronger position than ever to advance towards universal, affordable, and equitable healthcare. In this critical time, all of us rebuilding our lives from the COVID pandemic, I'm impressed at just how many new faces and new voices I'm experiencing in our healthcare movement. Let this be the force that drives us onward. And thank you all for being here today. Back to you, Cheryl.
Okay, thank you, Gina. Welcome, everybody. It's always energizing when healthcare advocates gather together to learn and strategize. And we have a packed program for you tonight. Sam Hatzenbeller from the Economic Opportunity Institute is going to frame up our discussion tonight by discussing how the gains and challenges from the 2022 legislative session will inform our work for 2023. Spoiler alert, the focus will be on equity, coverage, and cost. Andrea Caupain Sanderson of Byrd Place will kick off with a focus on equity. Andrea will tell us about Byrd Place here in the Central District of Seattle and share highlights from their report and survey on African American health in Washington State. Then we will delve into equity, coverage, and cost as they are being addressed in Washington State. Emily Brice from Northwest Health Law Advocates will talk about how we can drive down healthcare costs in Washington State, and then we'll open up for questions from you all. Kelly Powers, who serves as co-chair on HCHR's Universal Healthcare Commission subcommittee, will talk about how we are building a universal healthcare system in Washington State to address equity, coverage, and costs, and what you can do to help. And then we are excited to welcome Ming Chen from one of our newest HCHR-WA member organizations, the Washington Poor People's Campaign. He will explain the National Poor People's Campaign March to DC and the polls, including Washington State events for those of us who cannot make it to DC. And finally, WACAN organizer John Godfrey will guide us through making phone calls tonight to protect Medicare from privatizing by ACO REACH. David Loud, one of our Healthcare as a Human Right Washington co-chairs, will be our timekeeper tonight. David?
Hello, this is David Loud. I'm on the Puget Sound Advocates for Retirement Action Executive Board and co-chair the Healthcare as a Human Right Washington Steering Committee, along with Nathan Rodkey, who opened and may not have introduced himself, and Claude Burfect, Vice President of Seattle-King County NAACP.
Thank you, David. That sounds great. Now I want to introduce Sam Hatzenbeller. Sam is a Senior Policy Associate from the Economic Opportunity Institute. Sam and Emily Brice serve as co-chairs on HCHR's Policy Committee.
Thank you, Cheryl. So I am Sam Hatzenbeller, as Cheryl said, and Nathan, you can advance to the next slide. Thank you. And I want to begin our discussion tonight by reviewing the work so far this year. It's only the end of April, but we've already done so much, both at federal and state levels, and then also frame up what we're going to be digging into the next 6 to 9 months. So starting with federal, because that takes the longest to move, but it also has the potential for the largest impact. So far this year, we've been hard at work, continuing our federal advocacy with national partners, including regular meetings with members of Congress and Senate staff to lift up key policies to push for universal coverage, like Medicare for all, which is everybody in, nobody out. And we've also advocated for the state-based Universal Health Care Act, which will help empower states, like Washington, to give us the funding and regulatory flexibility we need to expand universal health coverage in our state. And of course, what has now become the infamous Build Back Better. We worked hard to push for that, and it included more than just important policies for healthcare, but also economic security for families, climate change, affordable housing, and more. We're not seeing that move now, but rumor has it elements are still being considered. So we'll still be at the table talking about those. And we know that ultimately we can't pass universal coverage here in Washington without federal action. So we're going to keep up our advocacy on that. Zooming into the state level, in our legislative session, short session, virtual session, we were still able to achieve some victories, and I want to highlight a few of those. We had a large platform, but I want to highlight a few victories. One in particular, we were able to secure with our partners $12 million in the final budget to launch not one, but two pathways for immigrant healthcare access, including an Apple Health lookalike program so that undocumented people will have parity or similar access as citizens. And then the second pathway is to pursue a federal waiver, which, if approved, would make Washington the first state in the country to allow immigrants to purchase healthcare plans on our state marketplace. A number of other bills passed this session to improve drug affordability, including a prescription drug affordability board, which can have the authority to review excess prices for patients. One bill on improving insulin affordability, and then another to prevent discrimination on cost sharing. We also advocated for a Balanced Billing Protection Act, which will further protect people from surprise medical billing. We know that that is a devastating practice that can drive people into medical debt for their lifetime. So that was an important one. And then we also worked with partners to advocate for a couple of different budget provisos to make Medicare more affordable. To read more about how all of the bills in our platform fared, you can check out in the chat our very detailed legislative recap. Now, some bills in our platform failed to pass. In particular, these are bills that were targeted toward regulating healthcare industry profits and controlling the cost of care. So these did not get enough traction, and this is largely due to enormous industry pressure from healthcare industry giants like hospitals. So we know here, I'm speaking to the choir, that while tens of millions of people in our country can't afford healthcare, massive healthcare corporations continue to reap enormous profit and pay their CEOs huge compensation packages. One bill that was targeted at regulating healthcare consolidations like mergers and acquisitions was the Keep Our Care Act. That was one of my personal favorites. This bill and bills like it are key to driving down costs for patients and holding large health systems accountable. That one failed, and then also the Safe and Healthy bill failed, and that one would have improved working conditions and wages for healthcare workers, who we know have been so hard hit by the pandemic and the recession. Bills related to equity also failed to gain traction this year or went backwards, including backwards motion on police accountability bills, the failed dental therapy bill, a failed bill to require language translation on prescription drug labels in pharmacies, and a lack of progress on affordable housing. So while it's important to acknowledge that we did win some victories and that these will make a big difference to people and people's lives, we still want to name, because I know so many people in this coalition, and we do the work that we do because we want systemic transformation. We want to see the Universal Healthcare Commission take bold action to advance universal coverage, and we want to fight structural and systemic racism and end racial and economic disparities. And we want to see corporate giants be held accountable and put patients before profits. So I think what I saw during the legislative session, when I'm really starting to see more and more of, is a growing frustration and a readiness, even by some Republicans, to rein in costs. And that's going to be important for us, I think, especially as we look ahead to 2023 session, because we're seeing signs that Democratic margins in Congress and also in our state legislature may grow slimmer and might even disappear in midterm elections. But the desire for change will guide our work over the coming year and as we prepare for next session. So we've created our program tonight to focus on these three key issues: equity, controlling costs, and universal coverage. So I'm super excited to hear from our awesome lineup of speakers, and I'll pass it back to you, Gina.
Okay, thanks, Sam. It sounds like we really have a lot of work to do this session, so hopefully we'll be able to get it all done. Okay, next, I want to introduce to you Andrea Caupain Sanderson, who is the CEO of Byrd Place, who will share with us the report on a survey Byrd Place conducted about how African Americans in Washington experience health and healthcare. For the past 18 years, Andrea has worked passionately to make a positive impact on issues of racial equity and poverty. As Byrd Place's Chief Executive Officer since 2008, she has built a strong foundation for future growth by effectively leading the organization through critical change and innovation. She brings a strong sense of leadership and vision to Byrd, an agency with a long legacy serving the community and providing lifeline services to the poor. Prior to Byrd, she worked for 4 years with the Washington State governors on African American issues, providing analysis and development on strategic legislative projects. Her work has involved legislative casework for the Washington State House of Representatives. She has a master's degree in public administration and a bachelor's of arts degree in the Evergreen State College. I want to welcome you, Andrea.
Thank you so much for that very warm introduction. Thank you for welcoming me here today. Again, my name is Andrea Caupain Sanderson, and I'm with Byrd Place. And at a high level, Byrd Place is what I consider this sort of unique ambidextrous organization where we provide direct services to our community, to low-income people living within the city of Seattle city limits. Many of you know us for our food bank, rental assistance, utility assistance. Now we have our water assistance program. We do light weatherization, and then we have our financial education program. And many of you also know us for our community engagement arm, which really harkens back to our beginning. We were created in 1964 by a group of Black pastors when, as you all know, the CD was redlined and it became a Black community. And we, as an organization, started as CAMP, or Central Area Motivation Program. And CAMP was a container to organize around those living and for those living at the intersection of poverty and racism. And we were also created out of the Lyndon B. Johnson's War on Poverty legislation. So we got the first set of funding from that legislation, which we still receive today. We're considered a community action agency. I heard community action mentioned earlier. We're part of that network of 1,000 agencies nationwide that cover every county in the United States, working with private entity and government to solve issues of poverty in our communities. The unique nature about Byrd Place is that we're also an identity-based organization compared to other community action agencies. We were created by the Black community, for the Black community, and have since expanded to serving anyone in need of our services. And back in those days, it was about the civil rights movement, right? And it now has evolved to Black lives. And so our community engagement arm is where this particular study I'll be speaking from today came out of. So next slide, please. Thank you. So part of the DNA of the organization is about policy and systems change work on behalf of Black Washingtonians. There are at least 300,000 of us living across the state of Washington. And yes, a majority of us do live in King County. The next largest population is in Pierce, Snohomish. But we are east of the mountains. We're in Port Angeles, right? We're in Whatcom County, we're in Vancouver County. And so this study does span the gamut of voices from across the state of Washington. And we chose to get into the data gathering business back in 2015, which is when this first study was published, Black Wellbeing and Beyond, because we understood that we needed to take command and control of the stories and narratives that were being told about us, about Black people. So we started to FUBU it, right? For us, by us. We started to gather this data both qualitatively and quantitatively to share with other Black-led organizations, but also to share with institutions who were interested in moving the needle forward for our Black community. So this particular study, Black Wellbeing and Beyond, is just a quantitative view of several pillars. We looked at the economic security of Black people, health equity, which is what we'll be talking about today, civic engagement, criminal justice, education. And so that particular study led to the And So We Press On study that I'll be talking about today. We chose to do just a quantitative version, and then we decided to do each pillar separately. So And So We Press On, which is what I'll be talking about today, is the qualitative version of the health equity pillar of this Black well-being and beyond study. And you know, initially we chose economic security, which we did. We did this one in 2015. Then we did economic security in 2017. Then we did this one, and so we press on in 2019. We chose economic security first because we understood that over 43% of Black Washingtonians was reliant on social services. We also chose it because we knew that it would take 228 years for the average Black family to catch up to the wealth of the average white family if nothing changed. And so we wanted to lift that up. But then we soon realized that there were forces in play to dismantle the Affordable Care Act, or Obamacare. And we knew that 1 in 5 Black Washingtonians would lose healthcare if the Affordable Care Act was dismantled. So that essentially led to us prioritizing and so we press on the health equity component of the study. Next slide, please. So we started our study, if you've been able to thumb through it, with this highlight, which is glaring. And we felt like this stats inadvertently proved our point, right? That African Americans constituted only, and I say only 12% of the total number of opioid deaths in the US, because we know when it comes to healthcare and access to healthcare that our lived experiences are ones where doctors, healthcare providers tend to minimize our pain, tend to minimize our experiences with pain, and tend to have an outsized view of our ability to handle pain. And essentially our pain was not believed. And that still is the case today. And it showed up here in these stats when the US started to really look at opioid addiction and what was happening with folks living in the US. And the connection there is that when we think about doctors' offices and healthcare providers, if they're not believing in our pain as Black people, if they're minimizing our pain, then they are not necessarily so quick to prescribe a solution to our pain. So thereby inadvertently, we were not as affected. We're still affected, but not as affected as other racialized groups when it came to the opioid issue. And that still continues to be the case today. And I just wanted to highlight that because what harkens back within that is that, again, when we think about healthcare and Black bodies, our pain was never taken seriously. And so we started with this quote by President Obama because despite the inadequacies that we see in healthcare for Black people living in Washington state, what we also saw in this qualitative data gathering is that there's been a sort of resilience within our people that can be attributed to mindset, right? Like this quote. So holding on to a sense of optimism is what we heard from people, holding on to a sense of gratitude and a focus on the future. You'll also see that connections, right? Connections to faith, connections to community, family, even self, and civic engagement. So organizing and activism is what sort of helped our Black people press on. So what we did with this approach to data gathering, yes, in the very first study in 2015, we administered surveys, we did focus groups, we did online surveys, in-person surveys for the qualitative view, and also understanding that people just in general in our culture have a hesitancy around talking about their health. And so we wanted to create more of a living room feel, kitchen table feel, very intimate. So we went into people's homes, we built relationships with people, we encouraged people, we trained the trainers to go collect data, but really meeting people where they were. We went to barbershops, hair salons, we even went to a few doctors' offices. But mainly we went into people's homes to really hear from them around a set of questions about, what does health look like for them? What does it feel like? What gets in the way of achieving what their health should be? We asked things like living environments, both in the house, but external environments. We also talked about resources for culturally appropriate care. So what you see here is just sort of an attention to the types of participants that we selected feedback from. So it was over 500 participants from across the state of Washington. It was important that we touched as many counties where Black folks lived, not just King County. 87% self-identified as Black or African American, and overwhelmingly the number of participants were women. We saw that the largest age group was between 45 and 59 years old, followed by 60 years and older, and then the younger demographics. It was important for us to meet as many intersectionalities within that data gathering. So 6% identified themselves as LGBTQ. And then what was interesting about this is that even though overwhelmingly African Americans are experiencing, and this is pre-COVID, economic insecurity, we were able to get feedback from a good spread of folks within our Black community from our social economic continuum. So 37% had household income between 75 and 150,000, with 18% having a household income of less than 50,000. And so what we surmise there is that there were people who of a specific social economic level within our Black community who were willing to talk about their health. Because believe me, we reached out to many more than 588 people, but these were the folks who were willing and comfortable to talk about their health. And so what we saw was that there was a higher income demographic who were willing, maybe even people who were more highly educated, who understood the importance of lifting up these stories, who were willing to come forward. And then of course we had 28% reported having children under the age of 18 in the home. So again, some anecdotal feedback from our community. We asked the question, right, for them to define for themselves, what does health look like and feel like for you? And some participants said health looks like a normal body weight, the ability to engage in desired physical activities, and rarely getting colds or flus. And again, this was before COVID, so I'm sure that feedback will be slightly different today. Feeling supported in your community, so including your employer, having a support network and access to good, equitable healthcare, which is what we're talking about today. And with providers who are interested in our well-being, culturally competent providers kept coming up. In terms of environments, having a safe, clean home and neighborhoods, right? And access to healthy food. We got feedback from folks who lived in healthy food deserts, affordable living, and safe places for their children to play. And so we also talked about what good health looks like and what it doesn't look like. And these themes kept rising to the top, right? Is that I do not have hypertension, I do not have diabetes, I do not have and never had asthma. I've given birth multiple times without any problems. I currently walk 4 miles a day, I kayak, I ride my bike, and I'm still healthy and Black, right? We wanted to also lift up the stories of what was working for people, not just from a deficit perspective, what isn't working. Then we also, of course, came across there are so many racist practices and policies, laws and rules in place. And it seems that brown people are under attack because white people are afraid of losing power. And this impacts every part of our lives and especially our health. And then also we had people who felt deeply grateful, right? I'm lucky to be working and have insurance. In addition, I can afford with my health benefits and income to be able to pay for my medications. I know I'm fortunate, however, many are not. And then there's this, right? Healthcare premiums don't allow us to see the doctor when needed. Then, of course, we kept hearing a shortage, right, of healthcare providers. There's an extreme shortage of medical providers that are people of color and are culturally competent. This person says, I drive 20 minutes away from my home to access a healthcare provider that is culturally competent. My family is intentional about healthy eating, exercise, and spiritual growth. We're all a little thick genetically due to the ramification of slavery breathing. However, we don't let that define us and we strive to be healthy. So here's someone talking about their model of health versus what the standard of model of health is. So this one is about, my environment, my external environment. When I moved into my house, a police officer approached me and asked me what I was doing at my house. And then my husband told them to leave and we filed a complaint. So you see police interactions with police and law enforcement also contributing to what we think about as safe place and health. Someone asked me if I thrive in Seattle. I had never thought about it before, but I do not thrive. Shootings and killings flash across my mind often, and I wonder if I have enough money, if I'll have enough money until I die. And so this is really about also mental health and safety and health and security in the home. My partner has an alcohol problem and is mentally unstable or bipolar, but feels he does not need to take medication. Taking fish oil tablets will take care of it, he says. Another one says, my father suffers from mental health issues and lives in the home with my husband, my mother, and myself. It's difficult to find good culturally relevant mental health services. The mental health issues leads him to drinking, and we manage this at home, and it's challenging. And so people talked a lot about connections, right? I think not allowing myself to wear a label that says I'm domestic violence victim or any of the issues that I had in the past don't define me. I can break the cycle if I want. And that is something that I do on a daily basis. Not living in the past is the best thing for anyone can do for themselves. And overall mindset, I touched on this earlier. We saw a lot of feedback. I stay hopeful by doing the best I can, tending to the parts of the garden that I can reach, things I can control. It helps to witness those I have affected positively begin to do the same in their own lives. And then engagement. I love this one, right? I show up at Vancouver City Hall meetings and allow them to see my face and speak up to the injustices, blatant and obvious racism. I encourage other woke folk to not hide or be ashamed because our Black, right? And always will be beautiful. And so I touch on those for you all because these are real people's lives, right? And I can talk with you about the stats, which is that we know healthcare isn't created equal, right? And then we know we see it in this, there's a personal choice versus systemic racism. There's some who do have choice and who do have control over certain things, but when you have to combat the system out there, then you lose your choice. We know what we saw overwhelmingly in our data gathering, both qualitatively and quantitatively, is that there is a deep need for culturally appropriate mental and medical healthcare providers and information. I'll wind it down so I can take questions, but what we saw overall, and again, this is pre-COVID, is that life expectancy in Washington state was 80 years. But for a Black Washingtonian, it's 76. And 15 years leading up to our death, we tend to lose our quality of life. We're talking about Black bodies in their 50s who become mobility impaired, chronically ill, and so on and so forth. And it just goes downhill from there, right? And so we think about access to quality care. We think about access to care in general. And then we think about providers who are culturally competent to serve our community. And there's just a huge lacking. So that, of course, leads to our poor quality of life. We see them coming through our doors at Byrd Place. Over 42% of the clients at Byrd Place who come to us for services are Black. And we see people in their 50s who are mobility impaired, who are chronically ill. And so we need to change this. We know that it takes a village, right? It takes our community, but it also takes our government stepping up. It takes our private entities stepping up. And so we're pushing for things like raising the medical reimbursement rate, or Medicaid reimbursement rates, right? Significantly to increase access to care. We know that we hear it from our clients, too many healthcare, mental health care, even dental providers who do not accept Apple Health and turn people away in need. And so we also are looking at the newly adopted Cascade Care Plan. We know that for a lot of Washingtonians who do not get employer-based healthcare and don't qualify for Apple Care are falling in that gap. So I'll pause there and take questions from you, but that's it in a nutshell for our Black community.
Thank you so much, Andrea. I learned so much, and I love how you really highlighted people's voices and their stories, and especially when the medical system is not believing Black people and not collecting data in culturally appropriate ways. This is so important. I know I have some questions, but I see some in the chat. From Gina, is Byrd doing something to spotlight more real human stories after realizing this report?
Yes, one of the streams of work that we'll be adopting, COVID sort of descended on all of us and shifted our priorities, and not that these stats in our Black community went away, but it was overlaid with COVID. But we're getting back along the stream of thinking around maternal mortality and preterm births. We heard a lot about that too. And we saw with the case of Serena Williams when she gave birth to her child and her experience and her economic status and still experiencing it. Me as a mom, both my children were premature. In fact, I was born, my mother gave birth to me when she was 7 months. I was 2 pounds when I was born. So it's inherent in my family as well. And so what we're doing is we're going to be setting out on a 3-year plan to collect this data, to observe what's happening with our Black moms across the state of Washington and raising up their stories. We want to be interviewing them. We want to be walking alongside them, but also using those stories to inform how change happens. We want to be looking at the region and other states to see what they're looking at around solutions. But yes, we want to be able to lift up the stories of our Black moms and what's happening with them in childbirth, and alongside them, co-creating how we tell their stories.
Thank you. Emily had one that I shared as well. Just what's the best way to lift up and support the work that you're doing right now?
Please amplify our messages on social media, in each of the spaces that you all may be, with government, with policymaking, systems change at the table, with discussions around change. Feel free to access data from our website, or bring me to the table, or reach out. I can provide you with information, but oftentimes we try to keep up to date with what we're doing in our data on our social media. Please amplify what we're doing from our social media channels.
Thank you. Yeah, I'm gonna look for that and drop it in the chat so that everyone can like you on socials.
Thank you. In fact, if I may interrupt briefly, because the 2015 study is slightly updated, or outdated rather, we're doing a re-up on that, on all 5 pillars. So towards the end of this year, a new iteration of the Black Wellbeing and Beyond study will be published. We've been spending the last year and a half gathering that data. We promised our Black community that we would not publish that data before hearing from them. So we're going out to community in June to present that data, to say, is this what we heard? Is this what you told us? We'll be publishing it and releasing that towards the end of this year.
Thank you. Yeah, just the community-based participatory research and getting consent every step of the way is you're putting forward a beautiful model. I think my question is, point of facilitator privilege, is, just saw the amazing investment in Tubman Center for Health and Freedom in the capital budget. And, and for folks who have not yet heard, Tubman is putting together, for Black people, by Black people health center, and wondering, I'm sure there's lots of conversations that have been had, but just seeing a lot of commonalities and for ways maybe the research you've put together can support their work too. And yeah, just curious for any thoughts you have on that.
Oh, we love Tubman. I often tell them that I have a vested interest in seeing Tubman rise and thrive, because I wish to be a patient at Tubman one day. I want my children to be patients at Tubman. So Byrd Bar Place is invested in Tubman. Both our social capital, our financial capital. We want to see them, their dream be realized and their vision for our community. We do share data. Their a study that will be coming out in a few months was a collaboration with Byrd Bar Place as well. We want to be able to sort of do this theory to action work with Tubman, where we have clients coming through our doors that need services. We want to be able to connect those clients directly to Tubman. We're hearing from those clients every week, their experiences, their lived experiences in health. We're able to use that to inform Tubman. So we're very much mutually symbiotic, Byrd Bar Place and Tubman.
Thank you so much, Andrea. I really appreciate you coming and sharing about this research.
Thank you for prioritizing this work.
All right. Thank you everyone for your questions. And just jumping along here, our next speaker is my co-chair, Emily Brice, and she is a senior attorney and policy advisor for the Northwest Health Law Advocates. So I'll pass it to you, Emily.
Thank you so much, Sam. And we are talking tonight about what ails our healthcare system. We just heard a powerful presentation from Andrea about work to tackle inequity, frankly, a tough act to follow. But it's time to name something else that's compounding that inequity, and that's rising healthcare prices. Someone is profiting off the healthcare system we have, and it is not us. So I'm going to take a little spin through the data that shows exactly what's happening here. Next slide, please. So first, we're going to look at the national picture over time, and this is not news to anyone, but after adjusting for inflation, total US healthcare spending has grown by 878% over 5 decades. Healthcare spending is now consuming nearly 1 out of every $5 in the US economy. And by contrast, other peer countries are only spending about 10% of their GDP on healthcare. Next slide, please. That broader trend in healthcare spending is reflected in our own family pocketbooks. And it's funny because I'm talking about data here, but like we all know this in our bones. It feels like healthcare costs are eating up a greater share of our budgets each year. And that is true. We're not imagining it. A national survey of employer-sponsored insurance showed that in the last decade alone, so just the last 10 years, average family premiums have increased by nearly 50%. Compare that to wage growth, only about 30%, and general inflation, only about 19%. So you can see the disparity. Next slide, please. Okay, but you say, surely we must be getting a better healthcare system for our money. Not so, and Andrea shared a little bit about that. We've come a long way in getting people access to health coverage through the Affordable Care Act, but too many of us are still struggling with healthcare costs, even during the pandemic when there was supposedly increased support for healthcare access. Something that shocked me is that half of US adults put off or skipped healthcare or dental care in the first year of the pandemic alone due to cost, not pandemic reasons, just cost, with disproportionate impact among communities of color, sadly. Next slide. Okay, but then you say, surely we must have better quality in our healthcare, right? Again, not so. In a comparison of peer countries, US ranks last over on healthcare outcomes with the highest infant mortality rate, as we're talking about, and lowest life expectancy at age 60. So sad. Looking at the 10-year trend in avoidable mortality, which is what this graph shows, the US reduced avoidable deaths by the least, only 5% compared to other countries. That's us way up in the outlier category. Next slide. Okay, this is not just a national problem. For the first time, we're getting clear data that shows that it's a Washington problem. This is really exciting. So new data from the Washington Office of Insurance Commissioner gives us a snapshot of healthcare spending over time in the commercial health insurance market. And it shows that from 2016 to 2019, healthcare costs for our fully insured commercial market increased by 13%, even though inflation only rose by 7% over that time. So we can see it now in the data, what's happening to us. Next slide. Okay, so what else can we see from the data? Not that one, the one, go back one. Thank you. There we go. There we go. What's driving this trend? We can see from the data that we are starting to see on a local level what's at issue here. And this graph shows the average price per service for categories of healthcare spending from 2016 to 2019, again in the commercial market compared to inflation. And take a look at that inpatient care line, that's that red line, way off the charts, and the pharmacy line, that's the green line, going way off the charts compared to the price for inflation, which is the dotted line way down below. So we're starting to see what is at the root of the issue. Next slide, please. Okay, so who cares about this issue of healthcare prices? I know everybody in this room. It turns out also everyone else. So new bipartisan polling shows that more than 2/3 of voters rank reducing healthcare costs as their top priority for president and Congress. 90% say it's important to take action. And really interestingly, as this shows, this slide shows there's broad support for government interventions to reduce healthcare prices. Next slide. Okay, so what can we do locally? That was a lot of data, a lot of different slides, and rest assured, this is the work ahead of us for the next 6 to 9 months to educate ourselves, get geared up for action on this. As Sam mentioned, there were bills in the legislature last year that started to tackle healthcare prices. And we as consumer advocates were not ready and mobilized to take action, frankly. So we left some possible wins on the field. This year, we want to be organized so it doesn't happen again. So we're hoping to work with the policy committee and the broader, all of us in this room and beyond, and the broader consumer advocacy community to dig into the healthcare price trends, educate ourselves about what's happening and why, and start making some noise about what's happening to us in Washington. We can start by learning, and this was already called out, but Sam wrote a great report last year that's well worth a read, a fun Saturday night read. And we're also tracking the work that's happening in the new state healthcare cost transparency board, which just set a healthcare benchmark that aims to measure healthcare spending over time in the state. And then we'll start measuring performance even by individual healthcare institutions against that benchmark later this year. I can tell you hospital and provider CFOs are watching that board like a hawk. They show up to the meetings. So why aren't we? And soon the state will start appointing representatives to the Prescription Drug Affordability Board. Those two boards together have the power to really reveal data on the trends of what's happening in our state. And we've seen that advocates in other states have been able to harness that data to start making changes. Again, why can't we? So as we start that work together, we can also lift up efforts that are already in progress. And many in this group, we already talked about the Black-led movement to raise concerns about the practices at Seattle Children's Hospital and recenter care in the community, as we were talking about. That's a space where we can work and look for opportunities for solidarity. So we are hoping to delve into these issues further in the policy committee. If you're not already a member, come on, join us, and potentially have some special events this summer that really would be for all of HCHR and the broader advocacy community. So we've been thinking about an advocates boot camp to help us kind of get geared up for action and get mobilized and educated on these issues, and really looking forward to hearing everyone's ideas. So that's it for me. Quick tour through the data, and I will hand it over to Kelly Powers, who serves on the HCHR steering committee and co-chairs the HCHR Universal Healthcare Subcommittee with Maureen Braithland. Kelly's going to take us through why universal healthcare is also vital to equity, coverage, and controlling costs, and give us some updates on what's happening with the Universal Healthcare Commission. So I'm really excited about that. Thank you, Kelly.
Thank you, Emily. I have to say, yikes, costs have really gotten out of control, and you're right. I was feeling it, but now I know for sure that it's really been happening. So Emily talked to us about how we could start bending the cost curve down. But over the long term, we believe universal healthcare in Washington state is key to addressing the concerns that we're raising tonight. Let's take a look at a New York Times article from last fall that features a Seattle not-for-profit. It exemplifies many of the issues we're spotlighting tonight. The article is talking about the bailout, but it lifts the curtains on some shocking finances of one of the country's largest hospital chains right here in Washington. This not-for-profit, now called Providence Swedish, sits on nearly $12 billion in cash. And this $12 billion investment fund is the golden goose that generates more than $1 billion profits in a good year, according to the article. Next, or click the screen, please, Nathan, thank you. Where did they get these profits? Well, according to the article, they partly got them from treating patients. And the article also notes that Providence Swedish sits on $12 billion pile of cash, whereas hospitals that serve low-income patients often only have enough to finance a few weeks of their operations. I mean, that is just unbelievable. So the Providence Swedish situation is so egregious that the Washington Attorney General sued. The lawsuit that he put forward alleges that hospitals sent more than 54,000 low-income patients' bills to debt collectors, even though the patients were eligible for free hospital care and discounts on their bills. So how do they prioritize profit over patients? What's going on here? Well, short staffing, underpaying workers, exorbitant CEO pay, and I don't have time, but there's a little outtake from Sam's report on corporate executive pay over there on the green. Prioritizing lucrative services and well-insured populations, not paying their fair share of taxes, favoring collection agencies over charity care, and if they're insurers, by denying and delaying care. And we all know it's easiest to deny those things to the most vulnerable. So the universal healthcare would shift the model from profit-taking to patient care. Let's turn to coverage and affordability. This chart shows that nationally, the underinsured rate, sorry, I got to be very clear because the terms are so similar. The uninsured rate, which is shown here in the light blue line on the graph, is falling. And it's really a huge accomplishment. And here in Washington, in the Office of Financial Management reports that the uninsured rate in 2019 was 6.1%. And by the end of 2021, in the middle of Omicron, it fell to 4.7%, thanks in large part to the Public Health Emergency Declaration. And because of the Health Equity for Immigrants campaign Sam mentioned, the state is pursuing new programs to fill coverage gaps for immigrants. So we're hopeful that it will fall even more. However, at the same time, more people are insured. The underinsured rate is steeply rising due to high costs. And we see that in the red line on this chart. So fellow advocates, we must begin to address the burgeoning problem of underinsurance, because if we can't afford to use our health insurance, what good is it? It is so clear that 40 years of market competition combined with anemic insurance regulation, it's just not working. Emily talked about the need to ramp up the regulation of prices right now, because right now they're completely out of control and there really hasn't been any meaningful state regulation, but we're going to change that, aren't we? Our movement has to do two things at the same time: improve the healthcare system we have while working for universal healthcare, the true long-term solution. The previous universal healthcare work group estimated considerable savings from a universal coverage solution, 2.2 billion the first year and 5.6 billion annually after the first year. These savings built the case in part for the legislature to form a permanent universal healthcare commission. And we're very lucky to have Hchrwa members on the commission who stand with us on this goal. And then to tackle the commission and engage with the commission and support the commission, Hchrwa formed HUCS, which stands for the Hchrwa Universal Healthcare Subcommittee. And that's our coalition subcommittee devoted to the commission and achieving universal healthcare in Washington. Not going to be able to go into this one, but we'll have the slides afterwards. But this slide shows the kinds of things that HUCS is involved in and the approach that we're taking. And we are striving to have a very coordinated, disciplined approach. I wanted to give you a little bit of a commission update and a HUCS update. The commission is focused on the November 2022 report to the legislature as specified in this bill that got its start. And they're looking to have a finance committee, which we expect in 2023. You can see here the kinds of things that HUCS is currently engaged in. We want the commission to get cracking on the finance committee as soon as possible. We are busy identifying sticking points and exploring potential approaches to universal healthcare. We're demanding solutions that ensure equity and we would love to make underinsurance a thing of the past. We're advancing our priorities on relative boards that Emily was talking about. So I hope you'll consider joining HUCS. You can email us at hchrwashington@gmail.com. And then I also wanted to put in a plug that these elections are just so critical. And I want to say, I hope that we are all make sure to support universal healthcare friendly progressive state and federal candidates in 2022. And so with that, I think Sam's going to open us up for question and answers, or not, maybe.
But Gina's question is, how can we leverage data like from Byrd Place and use that and to elevate that in our work for controlling costs and advancing universal coverage? I have some thoughts, but I'll open up to Emily and Kelly as well.
Well, thank you so much for that great question, Gina. I'll get us started. I'll say that's enormously important, and I kind of gave the high level overview, which really doesn't get into the granularities of what's happening on the ground. And I think I'll just share a reflection, which is that I see quite a bit of important room for work on healthcare prices to be informed by, led by communities of color, and in solidarity with other policies that other people might identify as well. I'm reflecting a little bit on a conversation that Sam and I had with folks from Tubman Center last week, and we're talking a little bit about healthcare prices, and some of the leaders from Tubman Center were saying, and I hope it's okay for me to share this, but we're saying that that this is a race equity issue, and that they would appreciate it if allies would name it as a race equity issue, because for too long the communities of color that are suffering most under the healthcare prices system that we have today, and are disproportionately impacted. And that is not an accident. It's a legacy of structural racism that is ongoing, continues today. And that's part of why members of that community have been involved in calling out Seattle Children's for their racist practices. So I guess I'll start there. I don't know if Sam or anyone really has something to add, or Kelly.
Yeah, I can just hop in that I think everything you said is right on, Emily. And also I think just with our current system that healthcare is a commodity, we know that people of color and other people targeted by other oppressions are always hit the hardest by that. And so it absolutely is a racial equity issue. And but I think to the point is also that we need to highlight people's stories as much as we can when talking with legislators, because that really can help drive home the actual impact on people, which I think is what a lot of legislators can also connect with as well. Kelly, did you want to?
Just that it would be just so great to get these voices before the Universal Healthcare Commission. And I was sitting here wishing, oh, I wish we could have this entire presentation put forward to the commission. That would be so great.
Absolutely. Yeah. And yeah, absolutely. I'm having so many thoughts. Okay, let's move on. Thank you so much. And okay, so now we actually have an ask for all of you. That, you know, these topics are all related, and we're really excited to get going on equity and universal coverage and cost and continuing our work. But many of you represent organizations and you're doing so much work to advance affordable and equitable healthcare. So we really, really want to hear your ideas and what you're really excited to work on. And that can also help guide what HCHR decides to take on over this next period as we prepare for next session. So going to drop a link in the chat to a survey, and Mo, you're still on top of it. That is the survey link. We're asking everybody to fill this out by next Wednesday if you can. And it's really going to help us get resources and ideas and help us achieve our 2022 goals and prepare for next session. So please fill that out. And Cheryl, I will pass it back to you.
Thank you, Sam. It will be helpful to learn the priorities and ideas from our supporters to help us plan our interim work. Next, Ming Chen will talk about the National Poor People's Campaign March on DC and to the polls, and he will share events around Washington to support the National March. Ming serves on the statewide coordinating committee for the Washington Poor People's Campaign and on the policy and research committee for HCHR. Ming recently retired from public health, Seattle and King County, after 26 years as a family nurse practitioner, providing primary care to low-income, uninsured, and uninsured persons, mostly living east of Lake Washington. Ming, take it away.
Oh, thank you, Cheryl, for that introduction, and thank you all for the opportunity to share. Today, I'll have to be a fast talker because I've got a lot to cover. Several years ago, as I was contemplating retirement, I thought I might sign back on with public health as a per diem, filling in for sick providers, keeping my skills up, getting to see some of my cherished colleagues and patients again. And I figured I'd have some time to help out in the fight for universal healthcare access. But then COVID struck, which changed everything. The pandemic gave me more time for reflection, and I realized if there's anything I learned in 26 years of providing primary health care to poor and marginalized people, it's that poverty makes people sick. My patients had access to health care. They had me. If they weren't eligible for Medicaid or Medicare, we provided care on a sliding scale basis. We never billed a patient, only reminding them of their balance due as they checked out and encouraging them to pay as able. We provided low-cost prescriptions from our own pharmacy, and we had a network of specialists who agreed to take on a rotating basis a limited number of our patients pro bono. But none of that matters if the patient can't get time off from work or childcare to come to their medical appointment, or can't get a ride to clinic or navigate a public transit system that doesn't adequately serve their neighborhood. I think of my patient, Augusto, who has metabolic syndrome, that insidious combination of high blood pressure, high blood fats, and high blood sugar. I could talk exercise and healthy diet until I was blue in the face, but it wouldn't do any good because he works 3 jobs to get by, from 5 in the morning to 11 at night. He barely has time to sleep, let alone exercise or prepare healthy food. Or my patient, Maria, an insulin-dependent diabetic who works in an East Side food court, whose employer won't provide access to refrigeration for her insulin or provide the privacy and time she needs to check her blood sugar and administer preprandial insulin. So I found my way to today's Poor People's Campaign, a national call for moral revival, which continues the unfinished work of the Reverend Dr. Martin Luther King Jr., who in December 1967 began planning an ambitious direct action campaign, the Poor People's Campaign, expanding the national conversation about civil rights in America by gathering people from around the country and from different races, different ethnic backgrounds who shared a common struggle with problems of poverty. After Dr. King's assassination, Reverend Ralph Abernathy and other leaders of the Southern Christian Leadership Conference continued to move forward with King's vision, resulting in the first multiracial demonstration in the history of this country to address the interlocking injustices of systemic racism, poverty, and militarism. And this was just over a year after Dr. King first spoke out against the Vietnam War. Over the first 3 weeks of May 1968, caravans set out from all across the country, including from Seattle, eventually converging on Washington, D.C. in late May, where Resurrection City arose on the National Mall. So this was a permitted occupation of national parks land. Its population peaked at about 3,000. It was even granted its own zip code, 20013. On Juneteenth of that year, over 50,000 people of all races gathered for a Solidarity Day rally at the Lincoln Memorial to remember Dr. King's I Have a Dream speech from about 5 years prior. But Resurrection City's permit expired on June 23rd, and police moved in to evict the 500 remaining residents, arresting nearly 300, including Reverend Abernathy. And sadly, much of the momentum of the movement dissipated after that. In 2017, the Reverend Drs. William Barber II and Liz Theo Harris began the new Poor People's Campaign, a national call for moral revival, taking up the mantle of the original PPC. And while the original campaign focused on economic justice and militarism, the current campaign also addresses environmental degradation, realizing that poor people and Black, Indigenous, and people of color tend to be the most harmed by environmental injustice and the least prepared to adapt to deleterious changes due to climate change. So I won't dwell on these next two slides, but just to give you a little perspective, the population of Washington State now is about 7.6 million. So the percentage of poor and low wealth people in our state is close to 35%. Nationally, it's about 42%. You saw in the first slide, my first slide, the 5 interlocking injustices the Poor People's Campaign is addressing. And for each of these injustices, or evils as we sometimes refer to them, we have a list of demands for our lawmakers, which you can see on our website. Here are some of our demands for addressing poverty. And as you can see, the Poor People's Campaign are all in on Medicare for all and for Medicare expansion in the interim. But none of that is likely to come to pass until poor and low wealth voters all over the country unite to exert their political will on lawmakers at the state and national level. As long as the labor of low-wage workers is exploited as it is now, even Medicare for all isn't going to be enough to enable many of those workers or their families to enjoy good health. So currently, most of our energy is in mobilizing for the mass Poor People's and Low-Wage Workers Assembly and Moral March on Washington and to the polls, scheduled for June 18th, 2022. So we have a short promotional video we're going to do it right now.
For the launch of the mass Poor People's Low-Wage Assembly and Moral March on Washington, D.C., June 18, 2022. We are new, unsettling force, and we are powerful new, unsettling force, and we are here.
We're rising up to demonstrate the compelling power that we, poor and low-income people, have to reconstruct society from the bottom up.
And we need to do it with the loudest voices possible, the biggest actions possible, because we know that there is no scarcity in this land. The only scarcity is the moral will to do what's right. Oh Lord, just a little while longer.
We are those with sub-minimum wage jobs who can't afford sky-high rent.
People with disabilities are the fastest growing minority group It's crazy to me that in 2021, it's still legal for workplaces to pay a sub-minimum wage to people with disabilities.
There are still so much trial and tribulations that we go through as Indigenous people. We can't get a decent wage to sustain ourselves, nor can we get adequate housing.
Veterans across this nation say enough is enough. We can't pat essential workers on the back on one day and then cut their health care the next day.
Health is a political choice.
What more do I need to do to prove that my voice is just as valuable as anyone else's?
There are still voices in denial that would try to slow walk our transition to a clean economy and a just future for us all.
We have an immoral system run by immoral people.
But together we walk and we fight. It's time for a change. Reconstruyamos esta gran nación.
See, we are people of resilience. As we fight these interlocking injustices together,
When we work together, mobilize together, and rise together, we become a voice for the voiceless, and we become an agent of change in a time where great change is needed. We need the third reconstruction to ensure that deaf people, people with disabilities, and all people can have the right to live and to thrive.
And I declare we have work to do. It is a moral abomination that there are 140 million poor and low-wealth people in this country. It's time to give everything we have to deconstruct the interlocking injustices that are all around us. If you got gray hair, suit up one more time. If you're middle-aged and if you're young, pay your debt for living on somebody else's sacrifices. Because it's time.
Do you believe that today? Come on, clap your hands if you believe it.
So we in the movement always say June 18th it's not just a day, but it's a declaration of an ongoing committed moral movement to, one, build power, two, to shift the moral and political narrative, and three, to make real policies to fully address poverty and low wealth from the bottom up. So the Poor People's Campaign declares we must do more: mobilize, organize, register, educate, and get as many people as possible who are poor and low wealth who are eligible to the polls and vote in 2022. Can I have the last slide, please? So if you are interested in helping us or learning more, you can put your name and contact info in the chat. Also, on the homepage of the National Poor People's website, which is on that last slide, you can enter your name, email, and zip code at the bottom of the screen, and you'll be automatically enrolled in the Washington State Poor People's Campaign Action Network, so you can receive our state-specific emails. For now, our fundraising efforts are focused on supporting impacted persons from Washington who want to travel to DC for the rally. We realize that it's not just the travel expenses and lodging and meals that are obstacles to participation for many, but also lost wages and childcare expenses. There is a donation link on the Washington Poor People's Campaign homepage, and I wonder, Ian, if you could put that website address in the chat, I'd appreciate it. We also have an upcoming fundraiser event. It's a benefit screening of the new film by Gilda Shepherd called Since I've Been Down, about our prison industrial system, injustice of mandatory sentencing guidelines. Perhaps Ian can speak to details of that too. You can consider going to DC for the mass assembly yourself on June 18th, or participate in solidarity with an action or viewing party closer to home. These are still in the earliest planning stages, I believe, so I don't have any details to share there. Also, just as the Washington Poor People's Campaign is a sponsoring organization for Hchrwa, so Hchrwa is a mobilizing partner with the Washington Poor People's Campaign. So consider asking your own organization to become a Poor People's Campaign mobilizing partner if its objectives overlap with the campaigns. And we need help establishing regional committees to help build the movement throughout the state over the long haul. or at least up until the next election cycle. Currently, there are efforts underway in Seattle, Bothell, Tacoma, Snow King, Grays Harbor County, joining the existing Lower Columbia Regional Committee. With that, we have, I guess, hopefully a few minutes for questions and answers, and then we're going to close with our traditional chant.
I think we have time maybe for 1 or 2 questions for Ming. Thank you. That was an incredible presentation. The video was so powerful, and the patient stories you shared at the beginning, the historical perspective was amazing. I have a question. I don't see anyone chiming in yet. How do we learn from previous movements that have gained traction and subsided? You mentioned a little bit about that, and I'm thinking about Occupy Wall Street. Remember that? What can we do differently this time? Is there something that we can kind of grasp a hold of coming out of the pandemic, particularly as there were sort of these enormous policy shifts in how our federal government was operating, how our state government was operating? What can we learn from the past?
Yeah, I'm not particularly wise in that area. I know that it's as we saw after the end of Resurrection City, it's really hard to keep momentum up on a mass movement like this, unless you have some short-term victories to point to that can give some people hope. And so, maybe if we see, if we come out of the 2020, the midterm elections, and we see that we still, progressive forces still have some significant influence in DC, hopefully that'll give us some encouragement to just keep going. Ian, do you have any ideas?
Yeah, the only thing I would add is, consider the amount of time it took to get to Resurrection City. A lot of the organizing started in the 40s, in the 50s, throughout the 60s. And so in terms of building a people's movement, developing leadership from the bottom up. And so we don't know where we are right now. We don't know if we're in the middle of something. We don't know if we're at the beginning stages of forming what will happen in 10 or 15 years down the line, or we might be right at the cusp of really accomplishing some of our policy goals. Even if we don't know where we are in that spectrum, it's important to keep organizing. For many of us, our lives and our backs are against the wall, and we don't have any choice but to continue.
I appreciate that so much. And also, we've seen, right? We effectively ended child poverty in one way during the pandemic, right? Let's not let it slip away from us just as we're coming out of this, knock on wood. So that is great. Thank you so much, Ming. And I think we're going to do a chat and a little take action. All right, we're going to do chant.
Chant. Yes. So in the Poor People's Campaign all over the country, the tradition is to close our events or our meetings with a simple chant, just a call and response. And I invite you to unmute and join me. I will say forward together, and you all answer not one step back, in keeping with that momentum idea. And we'll just do that 3 times. So you ready?
Yeah.
Forward together.
Not one step back.
Forward together.
Not one step back.
Forward together.
Not one step back.
Thank you so much. Love you all.
Thank you, Ming. Thank you. And don't go anywhere because we still have a little more in the agenda. Okay.
All right, everyone. I'll kick off the call to action today. And the question that prompted this is, why should young people care about Medicare? And from my perspective, young people care deeply about their relatives and neighbors who rely on Medicare. We don't want our families' health to suffer just to line the pockets of middlemen. And the ACO REACH program does this by privatizing Medicare and allowing Wall Street to take our tax dollars, cut services for Medicare patients without their knowledge, and keep a portion of the difference as profit. We want Medicare strengthened and expanded for ourselves and future generations, not hollowed out in a fruitless effort to satiate the greed of a few. So we're together going to make a call right now to the Secretary of Health and Human Services, Xavier Becerra, to ask him to keep Wall Street out of our healthcare and halt ACO REACH. So that was an amazing chant, but I want to make sure everyone gets back on mute, so everyone can do this effectively and stay together. When you're ready, grab your phone, and the number is posted right there on the screen, as well as our wrap. That's 202-205-5445. You won't hear the Secretary of Health and Human Services name on the call. It's going to be pretty abrupt when you make that call. It's just going to be like, the person you are calling isn't here. Please leave a message after the beep. And this is what you're going to say. Secretary Becerra, this is John Godfrey from Seattle. Please protect our Medicare, keep Wall Street out of our Medicare, and halt ACO REACH. So I'm going to go on mute myself and make the call. While people are calling, there's going to be a poll posted in the chat. And when you're done, let us know that you did it and how it went. All right. Calling commence.
I just want to jump in while folks are doing it. If you are getting a busy signal, please commit to trying at a different time. I just tried and got a busy signal, and I just want to inform folks, John and I did this earlier, and we're able to leave messages, but this is a separate line than the normal Health and Human Services line, because anyhow, I don't know if this line is actually set up for this. I also want to communicate that we initially wanted to set it up with the White House, but they only take messages at a specific hour, which is from noon or from 8 until noon Pacific time. Believe it or not, that is true. So if you're unable to leave that message tonight, please do it at another time. I'm concerned that it might be happening for some folks because I just got that busy signal and I heard it.
Yes, it looks like the line is not set up to take so many calls at one time. So it probably makes the most sense to skip the poll and just have all the 30 folks who are on this call commit to making that call at a different time. And I saw a question in the chat as to what to say. I will post my sample wrap in the chat for people.
So it looks like we are at the end. The wrap up is going to be really brief because we're like 7 minutes behind. So I'm just going to thank everybody for being here today. And I want to especially thank Ming. Washington CAN has also agreed to be mobilizing organization. So I was really interested and pleased to hear your presentation. I hope that everyone will reach out to Hchrwa or Washington CAN if you want to join the march in DC. And with that, I'm going to say thank you, everybody. Cheryl, do you have anything else to close?
I would like to say happy spring, and may we all make a splash for Pride Month in June.
Thank you, everybody. I hope you put all of your good of the order things in the chat because we did record this call, so we will be looking at all of that. Thank you, everyone.
Thank you so much, everyone.
Thank you.